Care of patients with disorders of the lower gastrointestinal system. When an individual maintains a consistent diet and activity schedule, the bowel motility remains constant. When an illness or diet and/or activity changes occur, diet motility is also affected. Gas-forming foods like legumes and those in the cabbage family need to be avoided. Avoiding onions, potatoes, cucumbers, coffee, tea, carbonated beverages, and alcohol can also be beneficial. For IBS that has an unknown cause, the abdominal bloating and the pain usually have a sudden onset with the production of flatus or abdominal gas. Stress, caffeine, and sensitivity to certain foods like dairy and wheat products seem to trigger IBS in some individuals. IBS is treated symptomatically to control the diarrhea or the constipation that one experiences. Gluten intolerance has been identified as a potential trigger for IBS symptoms. Diverticulum refers to a small blind pouch resulting from a protrusion of the mucous membranes of a hollow organ through a weakened area of the organ's muscular wall. Increases in intra-abdominal pressure from constipation and straining to defecate, obesity, and a low fiber diet appear to be factors in the development of colon diverticula. Diverticulitis occurs when the diverticula become inflamed or infected. Food particles accumulate in these pouches or diverticula. They mix with the intestinal bacteria, and this will irritate the mucosal wall. Diverticulitis of the intestine produces symptoms of diarrhea or constipation, acute left lower abdominal pain, bloating, nausea, and vomiting. Esophageal diverticula produce symptoms of dysphagia, regurgitation, nocturnal cough, and halitosis. The role of the licensed practical nurse or the licensed vocational nurse is to reinforce the education about diet, fluid intake, and exercise to individuals that have diverticula. Poor intestinal perfusion, drug side effects, especially narcotics, kidney disease, and infection can all interfere with routine or normal peristaltic action and produce a non-mechanical obstruction. Abdominal radiographs are ordered to locate the obstruction. The insertion of an NG tube relieves the symptoms by decompressing or removing gas, intestinal contents, and mucus. For nursing management, the patient is placed in the Fowler position. The nurse will monitor fluid and electrolytes, measure abdominal girth, and maintain pain control. The most common locations for a hernia are in areas where the abdominal wall is routinely weaker and more likely to allow a segment of intestine to protrude. This will include the center of the abdomen at the site of the umbilicus and the lower abdomen at the points where the inguinal ring and the femoral canal begin. Hernias can be congenital or acquired. A is an umbilical hernia, and B is an indirect inguinal hernia. The most common contributing factors in the development of a hernia are straining to lift heavy objects, chronic cough, straining to void or pass stool, and ascites. Hernias are classified as reducible where the protruding organ can be returned to its proper place by pressing on the organ, or irreducible or incarcerated. This is when the protruding organ or part of the organ is tightly wedged outside of the body cavity and cannot be pushed back through the opening. The surgical procedure that is used in the treatment of a hernia is called a herniorrhaphy. The defect in the muscle wall is closed with sutures. If the area of weakness is very large, a hernioplasty will be done. If surgery is not possible because of age or high surgical risk factors, the patient may be fitted with an appliance called a truss. A truss simply reinforces the weakened cavity wall and prevents protrusion of the intestines. A truss is not a cure for a hernia. Bowel ischemia occurs when the blood supply to the bowel is insufficient to support the metabolic needs. It can be an acute process with a sudden onset of symptoms, or it can be a chronic condition. The bowel ischemia may involve the arterial or the venous blood supply in the form of emboli, thrombosis, or the gradual narrowing and occlusion of the vessels. Ischemia can occur as the result of a bowel obstruction or as the result of hypovolemic shock. When blood flow is limited, the gut is bypassed in favor of the brain, heart, lungs, and kidneys. So, hypotension has more of an effect on blood flow to the intestines than to the other organs. A CAT scan or an MRI is used to confirm the medical diagnosis. Inflammatory bowel disease, IBD, this includes both ulcerative colitis, known as UC, and Crohn's disease. Ulcerative colitis is an inflammation with the formation of ulcers of the mucosa of the colon. It involves the rectum and extends up the colon in a continuous manner. It frequently is a chronic disease, and the patient is usually asymptomatic between acute flare-ups. Crohn's disease is a chronic inflammatory disease that involves all layers of intestinal tissue and can involve any part of the GI tract, but most commonly it affects the distal ileum and the proximal colon. Comparison of the distribution of disease and characteristics of the lesions of Crohn's disease and ulcerative colitis. For the area affected, for ulcerative colitis, it is the mucosa only, usually involves the rectum and proceeds up the colon. For Crohn's disease, it is full thickness of the intestine, and it is most common in the small intestine. For characteristics, ulcerative colitis, the mucosa is red. The intestinal wall is edematous and friable, bleeding easily, and pseudopolyps are present. For Crohn's disease, edematous bowel wall, inflammatory cells, mucosal ulcerations, granulomas, and skip lesions or normal areas appear. The signs and symptoms. For ulcerative colitis, it is diarrhea, frequently bloody, abdominal cramping that is relieved by defecation, and rectal bleeding. For Crohn's disease, it is fever, malaise, fatigue, weight loss, intermittent diarrhea, cramping or steady right lower quadrant or periumbilical pain, and postprandial bloating. For complications, for ulcerative colitis, it's massive hemorrhage, hypovolemia, toxic megacolon, which is a rapid dilation of the intestines, and cancer of the colon. For Crohn's disease, it is fistulas, anal fissures, perianal disease, bowel obstruction, or perforation. Expected outcomes of the plan of care. The patient's pain will be controlled with analgesia within 8 hours. The patient will regain fluid balance within 36 hours. The patient will experience a decreased number of diarrhea bowel movements within 24 hours. The long-term goals may be concerned with helping the patient adhere to the prescribed regime, encouraging effective coping mechanisms, and participating in the prescribed psychotherapy. Appendicitis is an inflammation of the appendix, which an appendix is a blind pouch, and therefore it is easily infected by bacteria that pass through the intestinal tract. Peritonitis usually occurs when one of the organs it encloses ruptures or is perforated so that the organ's contents, including any bacteria, are spilled into the abdominal cavity. The normal peristaltic action of the intestines slows or ceases, and the symptoms of paralytic ileus will occur. Unless the peritonitis is treated promptly and successfully, it can be fatal. Diagnosis of peritonitis is by history, physical exam, and the result of a CBC. A CT scan of the abdomen may be performed to rule out any structural problems or a tumor. Adult celiac disease, or SPRU, in which the patient cannot properly metabolize gluten, which is a protein found in all wheat products, barley, and rye, is one cause of malabsorption. Lactose intolerance is another cause because it can result in diarrhea. Pancreatic disease, with interference in secretion of pancreatic digestive enzymes, may also cause malabsorption. Malabsorption creates a nutritional deficit. Steatorrhea, or the passage of stool that is bulky, frothy, and foul-smelling, and routinely it floats in the toilet. The nursing management for malabsorption is to support the patient through the diagnostic process and reinforce teaching about diet and medications. Cancer of the large intestine, also known as colorectal cancer, is the third most common form of malignancy. Colorectal cancer is one of the most preventable and curable of all cancers. Cancerous tumor tissue may be polypoid, protruding into the bowel lumen, or it may be annular and extend around the bowel, causing a stricture. Other symptoms will include red blood in the stool, black tarry stools, a change in the stool shape, it'll be ribbon-like, abdominal distension without weight gain, sensation of incomplete evacuation after a bowel movement, and anemia resulting from intestinal bleeding. The treatment of colorectal cancer usually involves surgical removal of the affected portion of the intestine. Reconnection of the remaining intestinal portions, known as anastomosis, is done if the lesion is small and localized. This would be known as a hemicolectomy. A surgically created opening on the abdomen, or a colostomy, is needed to provide for the elimination of fecal matter. In an ostomy procedure, an abdominal incision is made, and either the colon, a colostomy, or the ileum, an ileostomy, is brought to the outside to drain fecal matter. The colostomy may be either permanent or temporary. Colostomies are identified by their location and whether or not they have one or two lumens that are visible. Sigmoid colostomies are the most common location. The first stage of a loop transverse colostomy is when a segment of the transverse colon is brought out through the abdominal wall and supported by a bridge. A slit in the bowel allows feces to drain from the proximal colon. The support is then removed 5 to 7 days after the surgery or when the bowel adheres to the abdominal wall. Ascending colostomy is one in which either one end or a loop of a portion of the ascending colon is brought to the surface of the abdomen to form a stoma. The stool from an ascending colostomy is watery and unformed, and it is usually a temporary colostomy. A transverse colostomy is situated toward the middle of the abdomen. Usually it is temporary. The stool here is soft and discharged unpredictably. A sigmoid or descending colostomy is located on the surface of the lower quadrant of the abdomen. It is the most common type of permanent colostomy, and it is done to treat cancer of the rectum. The stool from a sigmoid colostomy is more solid and well-formed and may be discharged no more often than once a day or every 2 days. Common indications for an ileostomy are chronic irritable bowel disease such as ulcerative colitis and Crohn disease, malignancy, and the presence of many polyps in the colon. Stool from an ileostomy is liquid, and although digestion is completed by the time the fecal material reaches the stoma, it still contains digestive enzymes that are highly irritating to the skin. Therefore, skin protection is very important. These are ileoanal reservoirs. The first one is a cock pouch where the stool collects in the pouch. The second one is an S-shaped reservoir. And the third one is a J-shaped reservoir. Preoperatively, the nurse will ensure that the patient has a low residue diet minimally 1 week prior to surgery. Roughly 1 to 3 days before the surgery, the individual should only have liquids. The individual will be given a bowel prep prior to surgery, and antibiotics will be given to decrease this infection of surgical sites. For ostomies, the nurse needs to understand that the color of the stoma should always be a beefy red color. It will appear moist. It is mucosal tissue, so it should be pink and moist, red and moist. There will be some edema until the incision has healed. The fecal output will depend on where the ostomy is placed. Ileostomy is always going to be a liquid that is in the small bowel. Ascending colon, it ascends up the right side of the body, and then the transverse colon goes across underneath the breast, and then the descending colon goes on the left side down the body and attaches to the sigmoid colon, which attaches to the rectum and the anus. So it depends on what part of the bowel as to what the fecal output will look like. The dressing, when applying an ostomy appliance, the hole for the stoma should be cut no more than 1/8 inch larger than the actual stoma. The fecal material is very irritating to the skin. As nurses, we need to make sure that the patient understands how to care for their own ostomy site. So we will educate them on providing care, and sometimes, especially if it's going to be a permanent ostomy, we will need to provide the patients with some psychosocial care, because they have a hard time with understanding this new life change. All right, the stoma is inspected for a normal pink or deep red color. This indicates adequate blood supply. It should look like healthy mucous membrane, like inside the mouth. A dark purple or a black stoma should be reported immediately. The skin around the stoma is also assessed for any irritation or signs of skin breakdown. The opening of the collection device is at least 1/8 inch larger than the circumference of the actual stoma. The nurse will provide accurate recording of intake and output, especially when they're caring for an ostomy patient. Total output of fecal material is calculated every 8 hours. The patient that has an ileostomy, which is the small bowel, must always be monitored for signs of dehydration and fluid imbalance. Remember that the function of the colon is to reabsorb water, sodium, and chloride, and to secrete bicarbonate and mucus. Once the patient is eating again, the ileostomy drainage is usually emptied 5 to 8 times per day. The pouch should be emptied when it is 1/3 full. The major reason that a colostomy would be irrigated is to establish a pattern of predictable bowel movements for the patient's convenience. There are 2 major principles to follow to protect the skin. They are cleanliness and providing a protective barrier to protect the contact between the skin and the discharge from the stoma. The appliances will be changed every 2 to 3 days to maintain an effective seal. After cleansing the area, a protective skin barrier paste, a wipe, or a spray is applied. This will prevent contact between the skin and the waste that is being discharged through the stoma. There are 2 types or kinds of pouches. There are drainable and close-ended. Drainable pouches are used when the flow of the waste material cannot be regulated and the contents need to be emptied more frequently. Closed-ended pouches are used only for security once bowel movements have actually been regulated. Hemorrhoids are varicosities of the veins of the rectum. Hemorrhoids may be internal, which is inside the sphincter muscles of the anus, or external, which is outside the sphincter muscles. Constipation, obesity, prolonged standing or sitting, and pregnancy are all predisposing causes of hemorrhoids. Pilonidal means having a nest of hair. A pilonidal sinus is a lesion located in the cleft of the buttocks at the sacrococcygeal region. When the symptoms are severe or persistent with abscess formation, the area must be incised surgically and the connecting canal will be opened and drained. The hairs and the necrotic tissue must be removed in order for the area to heal. Post-operative care will include removing the wound packing, cleansing with warm water 2 to 3 times a day, and redressing the wound. Site care will continue until the wound has closed. An abscess may form where there has been irritation with breaks in the skin or mucosa. A localized infection with a collection of pus forms an anorectal abscess. A fistula is a chronic granulomatous tract that travels in a line from the anal canal to the skin outside of the anus, or from an anorectal abscess to the anal canal, or the area around the anus. For nursing management, this involves education measures to prevent further incidents of constipation, as well as infection, and education about rectal hygiene. Sitz baths are used to help decrease inflammation of the rectal area.